as SIBO Awareness Day continues 2026. We're going to be talking about maintenance and long-term support with Erin Judge and Stephanie Mendez and preventing relapse. I know a lot of you have questions about that. Diet and lifestyle strategies, flare management, and transitioning off of treatment, because I get so many people asking us about what diet should we do, what table food should we do after an elemental diet. And one of the best suggestions I heard was just don't have a whole pizza. Like, just there's a baseline to start with. There's just like one little tidbit of advice you can have. We'll find out from you what your suggestions are. Okay, let me introduce our very special guests now. Thank you so much for being here on SIBO Awareness Day. We have Erin Judge, who is a registered dietitian, RDN, and founder of Gut-Of-8. She's a specialist in medical nutrition therapy for IBS, SIBO, and functional GI disorders. And then Stephanie Mendez, RDN, and gut health specialist. What a pleasure to have you both here.
For having me.
Yeah, thank you so much.
Thank you so much for spreading the word. Erin, I know you've got a big summit going on this month as well.
Yeah,
go ahead and give it the shameless plug, sister. Do it.
Celebrating all things IBS. So throwing SIBO in this week. We're actually doing SIBO next week. So lots to learn there, but a full month of free webinars for patients to get access to those out of the box IBS pieces of the puzzles. We've covered dysautonomia, mast cells today. We're talking supplements, we're talking diet, pelvic floor dysfunction, all the fun things that impact many of our lives. So it's completely free, still going on, and you can still join if you want to.
Great, great. And Stephanie, what have you been up to, Stephanie?
I'm the GI dietitian at Cedars-Sinai Motility Center. So I work with Dr. Azai and Dr. Pimentel and the rest of the team here.
Thank you very much. Okay. So you specialize in a low fermentation diet as well. Okay. We're going to get you some questions and we will take it from there. Okay. What are your core diet and lifestyle recommendations for someone who has a SIBO diagnosis? Stephanie, we're going to let you go first.
Sure. I'm going to do a high level overview of this because I think some of the answers we'll touch on a lot throughout the rest of the time today. But I have three main areas that I recommend patients focus on when they have a SIBO diagnosis. So the first would be to support motility. That can be done in a number of ways, but one of the ways could be to space meals apart, whether that's from 3 to 5 hours. And I'll go into a little bit more on that. Working with a dietitian to help support motility and give you more ideas, whether that's through diet or supplements. Gentle movements, whether it's walking, other exercises, or yoga, can help with motility and digestion. And then the second point would be to reduce fermentation without over-restricting from the diet. So when someone first has the diagnosis, this could be an area they might want to work on, is just to follow one of the diets or a version of the diet to reduce common trigger foods that they have. And then the last but not least would be to prioritize bowel regularity, especially if they're having a lot of constipation, really making sure that they know they have a bunch of tools they can use to try to optimize their bowel movement so that their SIBO doesn't reoccur. That can also include things like hydration, using fiber through diet or supplements, and then following their medical regimen that was prescribed by their doctor too.
Okay, that sounds good. Erin, what would you like to add to that?
Well, that was an incredible overview. Stephanie came very prepared and organized, which I love. The only thing that I would add is, and alongside what Stephanie said about like spacing meals, but really trying to optimize like the digestive process as much as possible. I do this for any patient, just because if we're looking at the gut needing to function well with motility or with proper digestion or whatever it may be, focusing on relaxing with meals as much as possible, chewing really well. And then depending on the patient, I may also alter meal size. So for most patients, it is maybe 3 larger meals spaced really well to support motility, constipation patients. But if you come to me with diarrhea, and if it's SIBO driven, we know at least, okay, we can address the microbial overgrowth and that diarrhea may improve. For some people, if you're having hypermotility and you lean towards frequency bowel movements, high urgency bowel movements, then we may alter some of your earlier meals in the day to be a bit smaller. So that spacing actually might be tailored a little bit more. So Stephanie mentioned there's lots of personalization in this, but making sure that we're supporting that digestive process as much as possible. And then even outside of diet, like improving toileting behaviors. And she mentioned supplements may fit in there in terms of helping support a daily bowel movement and bowel clearing and adding in movement between meals, ginger tea after meals, always to make sure we're optimizing that digestive process.
Okay, that sounds really good. And how can diets, including low FODMAP or low fermentation eating, support gut health during the early maintenance phase? Is just having that low fermentation and less burden on the body one of the ways to help prevent relapse?
Absolutely. I can speak to low FODMAP since that's what I use more. I love that Stephanie does low fermentation more. I've been a low FODMAP dietitian myself. But when we look at the low FODMAP diet, one piece of it is the fermentation property of these foods and how much gas is being produced. And so if we're trying to support the treatment process and we've tried to kill off some of these microbes, we've supported motility. Ideally, we don't want to overfeed these highly gas producing microbes as they're continuing to die off during treatment and after. So there is that side of it. With the low FODMAP diet, I think something that's also interesting that I take into practice, even though we don't have research in the SIBO space yet with low FODMAP, or I don't think low fermentation either. I'm assuming we're going to get
Not
that
yet,
research.
but it's coming, I'm sure.
May know. But when we're thinking about some of the IBS research we have on a low FODMAP diet, there are some studies that show that those who show up with kind of a dysbiotic profile, which maybe we could assume that that could be some of our SIBO population overlapping with IBS. The study didn't necessarily test for SIBO, but they looked at like kind of post-infectious IBS cases and these cases of IBS that had dysbiosis seen an increased intestinal permeability or that leakiness in the gut. When they followed a low FODMAP diet, that dysbiotic profile actually turned into kind of a normal, like healthy profile. And then, and again, not looking at SIBO, microbial overgrowth
Yeah.
of these pathogens, more so general overview. And they also found less intestinal permeability. They saw stabilized mast cells, which are immune cells that can impact the gut environment as well, like the reactions that people have to foods. And so if I'm using that in practice, thinking about a patient who's coming to me with, okay, they had dysbiosis fueled by possibly these pathogens and these specific microbes, they're going through a treatment process. Ideally, we want a less dysbiotic profile moving forward. There's some evidence to suggest that a low FODMAP diet may further support that process. So that's what I use in practice. And before I pass it over to low fermentation, I will say in actual practice, most people that I work with are already eating a pretty restricted diet.
Yeah, exactly.
So rarely in the maintenance phase of SIBO, I will say maybe 1 out of 10 people, we might start a low FODMAP diet fully. 9 out of 10 people are already restricting, usually FODMAPs plus plenty more. And so typically I actually use the low FODMAP diet to add foods. And so when we're thinking about incorporating foods that they had cut out whenever the disease state was very symptom causing, and now we've gone through treatment and now we're figuring out how to move forward, using lower FODMAP foods, maybe lower fermented foods, to start reintroducing some of these plant foods, these fibers into the diet, which the gut needs, gives us a bit of a pathway that feels safe and makes sense, right? That helps us kind of figure out, okay, this is what should happen. And ideally, these should be better tolerated, keeping all those different pieces in mind until we have more research to show us exactly what's going on.
And an expanded diet's always a great idea, of course. All right, Stephanie, for the low fermentation eating, how do you approach it? What are the things that you want people to know about that?
Yeah, the low fermentation diet is like an eating pattern that was developed by Dr. Pimentel and Dr. Rezai and the researchers here at Cedars-Sinai. And it mainly has 2 essential rules. So the first is to restrict some of the foods that contain high levels of carbohydrates that our bodies can't digest and that kind of get fermented by bacteria. And then the second one, we've already heard us say, but spacing meals apart. Per low fermentation eating, it recommends 4 to 5 hours. But I really do work with patients on what's more realistic for them and their lifestyle. But it was essentially created before the low FODMAP diet. So it wasn't actually meant to be compared to the low FODMAP diet. The idea was that they were getting a lot of patients coming in with SIBO. They were hyper-focusing on food, having a lot of stress and anxiety around food. And they wanted to just give them a guide to say, like, here, you can follow this guide and you can go out and live your life and dine out at restaurants. So you don't have to be super restrictive. So in that sense, if you looked at the details of the low fermentation diet, that's why you might see that some foods are allowed, like garlic and onion. And for that example specifically, it was literally because they wouldn't be able to go out to eat if we told them to avoid garlic and onion. So small amounts are okay. And we just wanted them to be able to have a little bit more freedom, but have some guidance still. So with the low fermentation diet, they are still reducing their overall fermentation load if they follow this diet. So there are a few of the big fermentable foods that are recommended to reduce, such as artificial sweeteners. So those are going to be things like sucralose and Splenda, sugar alcohols, so anything ending in OL like sorbitol or xylitol, your legumes and pulses, cruciferous vegetables like Brussels sprouts, broccoli, some leafy greens, and then prebiotic fibers and some dairy. So essentially, it's just supposed to be a little less restrictive, keeping the big key players reduced in someone's diet who has SIBO. So those are the main points I touch on. It can be followed a little bit more long term, and patients do find it a little easier to follow, but I can definitely go into it more. I think some of the other questions will have me go into it more as well.
Well, one of the questions is, let's see, regarding meal spacing of 4 to 5 hours, I think it says, can I eat at least for 1 hour and then take a 4 to 5 spacing? Like, how can they pulse that? Is there any, it's to get the migrating motor complexes, get that sweeping wave going. So that's why a lot of people I know take prokinetics at night, and then they have a nice sleep and a nice fast. And then throughout the day, how do you help people with that? Obviously, it's going to be custom, and blood sugar is involved and all of that. Do you have any cheats for that? Is black coffee okay? Like, what are some tips for the meal spacing?
Is the question asking if they can have anything during those 4 to 5 hour periods, or how do you do it? Okay.
Let's do a little of both. It's a little cross-pollinated, the question.
Yeah, ideally, you're not really consuming anything else but water during the 4 to 5 hour break.
Okay.
But with that said, I even have patients who a lot of times our SIBO patients have other comorbidities that need to be honored. Like you said, blood sugar, or they are losing weight, but they're having a lot of symptoms. So this is a case where might start them off with a 3 hour spacing so they could still get 4 to maybe even 5 meals in that day, slowly work them up to a 4 hour spacing, see how they feel. I personally rarely have someone get to 5 hours. I think it's pretty hard.
Okay.
Yeah. And then I also work with them so that they're not hungry during that time, right? So, optimizing meals, making sure there's like protein, carb, fat in each meal, or having more complete snacks if they're throwing a snack into the day. So the idea is not that your current meals aren't optimized and you're just going long periods without eating while you're really hungry. I would actually, if that was the case for that patient, I'd prioritize optimizing their meals before spacing if they were having some difficulties.
That's good to know. It's already torturous enough to have SIBO,
Yeah.
right? Much less that you're now really hungry all the time. And sometimes I wonder about fasting in general and all that. I wonder if some of the benefits that everybody seemed to experience for several years when it was sort of very trendy was that their migrating motor complexes were actually working more effectively. And, it's kind of a little giggle, and I'm just glad it's helping people. That's the main thing. Erin, did you have any tips for the meal spacing?
Those were great tips. I will say that I also don't typically get to 5 hours. I try to aim for 3 to 4, but really just seeing where someone is starting. And again, looking at how their day flows, I find that usually if we get that overnight fast really strong, people tend to be moving their bodies in the morning. I tend to space morning to early afternoon meals tighter, just because that seems to flow better with kind of more slowly easing into digestion. And then maybe having a bigger space in the afternoon and then that dinner. One tip that I usually will give is if you are going to have coffee or tea, put it with the meal. And the same with dessert, because people get kind of confused on that in the evening. I'm very pro dessert. I love dessert. You should have fun things, right? Make sure that you're putting that with that meal in the evening, because that can help a lot. And then some people do need to work on efficiency of eating because if you are eating over an hour of time, or sipping on a smoothie for an hour and a half, usually that's you're probably distracted. That efficiency piece that I mentioned before might not be at play. So we may need to work on chewing. And if we're not doing a good job at that, maybe decreasing the particle size of a meal. I don't know if you guys have talked about that with how the elemental diet is the lowest potential particle size. A salad versus a soup is a great example. A salad's going to take you much longer to eat. A soup is going to take you a lot less time to eat if you're actually doing it. So that would be just another tip to make sure that, okay, what's actually going on with this meal? And then what else is happening? And, the migrating motor complex, it's great, but it doesn't have to also control your life. If you're overly stressed that like you're not spacing it well, and then you're panicking about that, and then you're not eating well, like you may throw your body off and your motility off if you're undernourished or you're fasted for too long. You can get into the weeds of that in a way that actually works against you. And so to doing your best, figuring out where you're starting. And then the big goal is just not eating and grazing all day long. And that flexibility can come a lot more too as you get past treatment and you see that symptom response and your gut's working well and some of those signals.
It's multifaceted for sure. Do you recommend a low FODMAP or low fermentation diet during antibiotic treatment?
I can speak to my approach. I typically start wherever the patient is. Again, I would say 9 out of 10 of my patients are already restricted going into their treatment. Most of them, as you guys have probably talked about, have suffered with symptoms for many years before they even got this answer, and those symptoms had progressed. And so usually food gets cut out. So I usually will say whatever we can get in terms of symptom response. I haven't seen anything to convince me yet that we need to add a lot of FODMAPs to the diet during treatment. And again, I missed earlier, so please tell me if there's something I'm missing. So I usually will just pair it to the patient of if we feel better already pulling back some of these highest trigger foods, whether that's just your highest FODMAP foods or just like beans maybe, or just salads. I typically do that to get through treatment well. And then I typically stay pretty hands-on during treatment because some patients have symptoms, some don't. And then we might monitor diet and change a few things based on the symptoms they're experiencing to see if we can just ease some of that, the GI side of it. And patients who are doing great during treatment, I let them know in advance, like, if you feel amazing, eat the foods, like you're not going to ruin it. And if you do, we probably didn't treat it properly anyways, right? So it's okay to eat those foods that you love with some caveats of like alcohol and maybe ultra processed foods, but I'll let Stephanie share her approach.
Yeah. What are your thoughts, Stephanie?
Yeah, mine is similar. I don't really recommend any diet changes when they're going through antibiotic treatment. So I won't start someone on a low fermentation diet if they're going to start a course of antibiotics. My personal reason is I really want to see how those antibiotics are affecting their symptoms. And if we change too many interventions, we don't know which one was helping. The only other case of it, they've been on a low FODMAP diet for a really long time, they're doing antibiotic treatment, I won't reintroduce or have them come off of it during that time either. I'll wait till they're done with antibiotics, then we can do a reintroduction process.
So the fact is that, guys, if there are calories being introduced, the body will not do a migrating motor complex sweep, right? So is that accurate? Right. So to say, like, if I want to have a piece of fruit to hold me over, that's going to have calories to it. So it's just, you need to decide what windows are going to work for you. Maybe you're doing it every other day. Dr. Seebecker and I did a SIBO Diets masterclass. The content was about an hour and a half, and then it was 5 hours of Q&A. And literally, if I had $1 for every time we said, everybody's different, experiment with it, see how it works for you. And of course, there are the outliers that you've been talking about, like garlic and onions and apples may just be like off limits for most people. I have a friend who has SIBO. She was able to do garlic, no problem. Give her an onion, she's going to feel like she's deaf. So it's a little frustrating, I know, as a patient to keep hearing that, because you're like, just someone take me away and like just make my food for me and make sure it's tasty and just like be in charge of me. But you cannot give your power away, ladies and gentlemen. You have to work within this very frustrating, very personal aspect of treatment, which is your food and your diet and the socialization. And that's really where I think nutritionists and registered dietitians are some of the most underrated supports when you do have SIBO, because they really have a lot of ideas and a lot of experience and can suggest so many great things. And just shout out to y'all, you're not utilized enough. So there you go. Okay. I have a lot of opinions about that. All right. How can someone recognize early signs of a SIBO flare?
Great.
I think that's going to be a quick answer, but go ahead, Erin.
Yeah, I mean, I would say the symptoms, which is hard to say. Usually for my patients, I tend to look at motility changes first. We look at motility a lot, probably get annoyed at how much we're tracking motility, like how much volume of poop is coming out every day. It's like people get really skilled in knowing how well they're emptying and clearing. I will typically see a change in motility before I see like the pregnant belly bloat come back. Sometimes pain, I will say, will increase first. But obviously, if we're like back to, okay, I'm usually doing fine, and then all of a sudden I am extremely bloated. I'm very gassy. My bowels seem all over the place. I would call that being in a flare. But Stephanie, I'm curious about you because I know you work with even more within your clinic, how you address those flares.
Yeah, I think especially if it's a reoccurrence, right? If it's early signs of SIBO, it's their first time, they might not know they have SIBO until they've had it for a really long time. But if it's a reoccurrence, patients usually I see similar symptoms come back that they have. So if they have a lot of bloating, they're going to see a recurrence of a lot of bloating. Whichever bowel movement predominance they have, that can return, but it can also alternate. So if they had methane and they got treated for methane with constipation, then they can actually have hydrogen on the next breath test.
Right.
And they might have a little more diarrhea. We also see like brain fog, fatigue, especially if they're starting to get deficiencies, and then an increase in food intolerances. If they're paying attention, some of them are like, oh, I can tolerate lactose, or I used to be able to tolerate lactose, and now I don't anymore. And there's something that has switched.
Yeah, I will add, I think this is interesting and I'm curious to hear Stephanie. I'm using my own time to talk to my colleagues. Something else that I think is important with that, because it's easy to say, like, you have symptoms come back. That means that there could be a
Mhm.
SIBO relapse. It's also common. Someone asks about when do I trial new foods? Like, when do I start
Mhm.
incorporating new things? Symptoms can still happen, even though SIBO may not be fully relapsed. So a
Yeah.
lot of people have motility disorders or reasons for motility concerns, whether that's hypermobility or nerve damage, or I know you guys have probably talked about this all day, right? So there's a lot of different causes of symptoms, and having a day where you were trying new foods and you had a spark in bloating, that doesn't necessarily mean that it's a SIBO relapse and we need to retreat right away. Like, there is sometimes a look at what else is going on, what can we adjust, what can we understand about the symptoms you're having for a day or two, menstrual cycle changes. There's so much that
Yeah.
can contribute to symptoms. And also, I always say normal, hate the word normal, but people without GI conditions or problems have bad GI days. They have food that they eat that doesn't work for them. They have travel induced symptoms. They have stress induced symptoms, like their bowels get out of whack sometimes. And so we have to also understand that. I typically will think about, okay, this is maybe a SIBO relapse when symptoms have started, like they're getting kind of funky. We look at the picture, maybe we identify a few areas that we might make a few tweaks and adjustments. Maybe we expanded their diet, alcohol's been reintroduced, they're traveling, they're eating out more. Maybe we pull back a few of those things, find a baseline. If we can't get back to a baseline within a few weeks to maybe even a month in my more severe cases where there's a lot of complexity, that's when I start to suspect that there might be a need to maybe retest, relook at the SIBO picture. But Stephanie, I'm curious about what you do, because I know there's no perfect science to this. It's more of the art of it.
Yeah, I think Erin made a great point that I always tell patients when they're reintroducing a food, if they have mild symptoms, that could still be normal. If you haven't had a food in a long time, your body will have some nuances when it's adjusting to it. I agree. I think it's going to be like symptoms are kind of pretty persistent day in and day out, despite maybe some minor changes, but it's usually not a one-time thing. Like maybe one day you had a super high fiber day, you're really bloated for 3 days, and then everything's fine. I usually see that it's more persistent symptoms that are not going away with maybe some easier management tools.
I had some chia pudding the other day and thought I was going to die. But I didn't think like, oh, my SIBO's back, because it was just like, I shouldn't have had 2 servings of it. Okay. Is chard considered a green leafy vegetable to avoid?
It is a leafy vegetable, but it is one in the way that like we cook it, or we usually cook it, right? It's usually like cooked chard. So it's one of those that I do tell patients, like, you're going to have it, add it to the end of your soup cooked. Make sure you're modifying it in some way before you're getting it into your belly.
Versus using it as a wrap. I've seen it as like a
Yeah.
wrap alternative. Okay.
Yeah.
I follow Dr. Pimentel's low fermentation diet. I am better. Great. But when can I try adding something back? Like, for instance, oats or grains. I am on antibiotics for the past 6 months off and on.
Yeah, they're feeling better. And they chose 2 foods that I think are generally well tolerated, like oats and grains for a lot of our patients. So those are actually some of the foods I usually have patients reintroduce. You could still do small amounts if you want to at a time and slowly increase. Like quinoa is a grain that tends to be pretty well tolerated, but they still have fiber. So depending on your current fiber intake, you might just want to take it slowly as you're increasing. But yeah, as long as you can kind of tell a difference in your symptoms, if you were to eat something, obviously we said you want to have it multiple times and not just take the first mild symptom saying that you can't tolerate it, but it would be a good time to reintroduce some foods.
Okay. What strategies are most effective for managing a flare when it occurs? We've kind of touched on that, but do you go, broth? What do you do for your peeps when that happens?
I keep my clients eating as much as possible. Again, unless I get some severe cases or patients also know themselves. And so if a patient knows that maybe an elemental protocol for a couple of days or doing a broth, maybe extending a sort of semi-fasted period works for them, great. I typically don't recommend that. I like to keep the gut fed to hopefully get out of that flare as much as possible and like keep motility moving. One thing I will do is I will often pull back into the lower FODMAP, like safer foods, and that is very personalized. Again, based on the person, what they've experienced, what we've found out. But typically, again, lower FODMAP, lower fermented food. And then I do decrease particle size. And so, like I mentioned before, instead of going for, if we've progressed to things like salads and bigger meals and even cooked foods, but let's say we're doing like a whole baked potato, or we're doing a lot of cooked greens, or like even broccoli florets, something like that, that's going to take up a lot more space. During a flare, I may recommend that we chop things up even more. Maybe we blend them. Soups tend to be a great approach that I will use. I say no alcohol. I know alcohol is a tricky one, but that is obviously our biggest gut irritant. And a lot of people in the SIBO world cut it out and they're fine with that, which is probably the best move. But if someone has wanted to bring that back, or excess caffeine, then I may try to pull some of those things back. And the biggest thing that I recommend is, okay, let's look at the full picture. Are you sleeping well? Are you panicking? Do we need to calm the body? Not that stress caused it all, but do we need to calm the body down, take a period of rest? Are you overstretched? And can we somehow take some things off your plate? Give yourself a period to rest, just like you would do during a SIBO treatment. Are you moving your body gently? Or are you holding everything intense because of that flare? Can we find ways to incorporate a little movement? So it very much is personalized, but trying to get back again to that baseline as much as possible.
Did you want to add anything to that, Stephanie?
Yeah, I agree with everything Erin said, especially reducing known trigger foods. Like that might be the time where you pull back. And this is also a great time where supplements can be used. So maybe this is, I think I saw somewhere in the question about FODzyme. I love FODzyme. It's been very helpful for a lot of my patients, but especially if it's a flare that has occurred and it's like the 10th flare they've had and they're tired of having to change things in their diet, but they know, oh, FODzyme works well. That might be the time to start using it a little bit more often. This is where you can start with fiber supplements if your bowels have changed, or certain like peppermint supplements to help with bloating if that's a symptom. But I really always look when I'm working with patients as dietitians. Sometimes we have to talk about things black and white, but individually when we're working with patients, I don't usually say, oh, start the low fermentation diet. I'm like, all right, I know you pretty well. Seems like you might be eating some of these trigger foods, or you're really stressed right now. Let's not even talk about diet. Let's talk about some non-diet therapies. Maybe it's like a gut-directed hypnotherapy app. Maybe, like Erin said, focusing on sleep if you're not getting any sleep. So I think there's definitely a lot of tools, and I think it's really like what the patient needs the most at that time for that flare.
And in terms of like malabsorption, SIBO is a malabsorption condition. So that smaller particle size, digestive enzymes like FODzyme or what FODMAP, there are some really powerful ones out there that really can help. And just really focusing on getting that overgrowth down so that those bad players aren't stealing your nutrition and you can get the microbiome back online. And, hunger noise, which you hear a lot in the GLP world, and how GLP-1s have helped with hunger noise. And I know genetically, some people are more predisposed to hunger noise. Food noise is the word with phraseology, but I think everyone knows what I meant. And then you want me to not eat for 3 to 5 hours. Do you ever do like an essential oil? I have someone asking here about what's your experience with electrolytes containing no calories but stevia or monk fruit, or both, during the 3 to 4 hour time window between meals? Erin, go for it.
I'm actually not sure. Have they looked at the impact of stevia and non-caloric sweeteners on migrating motor complex yet?
I think Dr. Pimentel is not a fan of stevia for the migrating motor complex.
That's what I believe. I think that
Yeah.
the general rule, I guess, with limited data, like we're working off what we got, I believe that it is not using non-caloric sweeteners. I probably honestly wouldn't do electrolyte, I guess, depending on the patient. Like electrolytes can sometimes support motility. Sometimes they may make you poop more. So you have to be kind of careful with like timing of electrolytes. I would not do that. I don't know, Stephanie, do you have any opinion on the non-caloric sweeteners during fasted?
Yeah, I agree with Siobhan that we don't really prefer stevia, monk fruit either from a low fermentation diet, but I have found it is almost impossible to find a product that does not have monk fruit if it does not have regular cane sugar. It's just what is being used in almost everything right now. But yeah, I think if I was working with the people who have been asking this question, it probably wouldn't have you probably space your meals if you're trying to find something to eat in between these times. So maybe there are so many other interventions we could use for you that
Right.
wouldn't make you feel like you're giving up so much for these 4 hours or 3 hours. But for stevia monk fruit, I would not use those if someone has SIBO to the best of their ability.
What about like lemon water? Is there a calorie in there that would impact the migrating motor complex, do you think?
Probably. I know people are kind of iffy on even like black coffees. You get like
Right.
calories per
Yeah.
cup. I
Yeah.
think that how big of a difference does it make if
know.
you're
Yeah.
doing that once? And again, I think that's looking at the day in a bigger picture, because if
Right.
it is like, oh, well, my morning, I'm trying to figure this out. You just had that overnight fast, like every single meal doesn't have to be spaced that perfectly to get the benefit. And again, more severe cases, you may approach that differently, but I would not if you're really trying to test it.
Mhm.
But I also, like Stephanie said, if you're a grazer, like you're snacking, eating, you're drinking flavored liquids all day, like that's your approach currently, I would not start you on a 4-hour fast between
Right.
meals
So
every
let's move
day
off of that. Right.
tomorrow.
Yeah.
Yeah, I would probably say, okay, let's space like dinner, like let's tighten up your dinner and after dinner snacks, and then help maybe before bed. And then I would probably go before dinner, what's going on? Are you exercising? What's happening there? And then I may work to lunch, like kind of working one meal at a time and only spacing a little bit more than where you currently are, so that you can test that, like, okay, do I need to add more fat to this meal? Do I need to add more protein? Do I need to add some fiber? Because if you've stripped your fiber, your meals are going to be a little less satisfying, and we might need to bump fiber or protein and fat for a little bit while we're building up fiber, but we also may need to incorporate some with meals. So I think it's a lot more creative than that. And so if you are struggling, I would say if you have a dietitian, make sure you're telling them that and asking, like, hey, I need to figure this out. Like, I'm not fitting into this perfectly. I need to figure out these trouble points. If you don't, find one if you can. I know we're not all available, but also thinking, trying to, and this might help with like finding a friend or finding someone that you trust, of like having an open conversation. So where it's like, okay, here's the plan. I'm supposed to space my meals. Here's my problem. Think about it as if it's not you. How would you troubleshoot that, right? Because some of it is a little logical. We just get our logic taken out a lot when we're also dealing with symptoms and we're trying to do our best and we're in the mix of it. So that can help if you're trying to guide yourself of like, okay, I'm struggling with this. What can I do? And again, one meal at a time, just tightening up so that you can really test how you feel. And then if you have a little bit of flexibility at a certain point of the day, you're still likely better off than where you started with your other meals of the day being spaced well.
You
The
sound
same
like
is
you're
true of, like,
doing a chat
fiber
GPT
intake.
prompt, Erin. Like, right, which is
Yeah,
great. I've done that
that's
before.
great. I'm pro that. I
Yeah,
think
take the food list that you're supposed to be dealing with, and you're like, okay, I don't like peas, I don't like cabbage or whatever it is, and say, you know, I'm a picky eater, whatever, and use ChatGPT and then use it in conjunction with human intelligence and work with your provider. And it can come up with some really wonderful meal plans. But the borderline to not cross is hypervigilance, right? Because that's when it gets quite, I don't want to say dangerous, but it can be scary. And you can be like, oh my gosh, I just don't think this is sustainable. And if it does feel sustainable, it might be a problem because this hypervigilance is not serving me well. And one of the questions that we had pre-planned to ask was about the mental, psychological, and emotional state of being on a somewhat, I want to say, restricted diet with flexibility. And, you know, it's easy to get a lot of decision fatigue around all of this, which is why we have so many questions going, what about this? What about this? What about this? What about this? And I get it. Believe me. I remember standing in my kitchen back in 2000, I don't know, 15, going, an apple a day keeps the doctor away. I'm hungry. I'm going to go have an apple. And I was just like, whoa. So, you know, it's a lot of decisions. You need the science, but also you need to relax into it at the same time. What's your best mental health advice, knowing you're not a mental health professional, but you are a highly skilled professional in this field? What's some advice that you give to your clients? Either one of you, go for it.
Yeah, so I am also someone who has long-term GI issues and I have SIBO myself. So I am in your shoes. I get the toll that it takes when you're trying to just function in life. And my biggest tip is to normalize your emotions. I think when we have GI issues, it doesn't feel good if we're negative about it or when we're angry or sad or all the negative emotions that we have. I mean, it feels better when we're in our positive moods and positive states, but I just want to normalize that it's okay to feel all these different types of ways about your condition, especially as women, our hormones change on a daily basis. and that might affect how we are perceiving or how we're feeling and doing that. So I think the more we can tune into how we're feeling and honoring what we need and really tuning into that can be so helpful. And that I do want to touch on one part of this too, is that right now we don't have almost any research outside of elemental diet on diet and SIBO. So if this has caused you to like really hyper focus or try to go in the weeds of diet and what to do, I've had patients that follow low FODMAP or low fermentation diet to a T and their SIBO comes back. Patients who don't follow anything and their SIBO comes back, and vice versa, where they could do whatever they want, the SIBO doesn't come back. So there's no guarantee. And I say that more to just give you some relief. If you're having a week, if you're a parent with children, if you're traveling, if there's something going on in your life that you can't follow what you've been following for the past few months, that's okay. And sometimes we need that. And there's always things we can do to get back on track. And the other piece that maybe, Erin, you'll touch on more too, but those non-diet therapies are so helpful. I'm also a yoga teacher, so really like love diaphragmatic breathing, abdominal massage, movement, gut-directed hypnotherapy. There's like all of these tools in our toolbox that we can pull out and use based on what we need and how we're feeling in that moment.
Absolutely. Those are such good tips. I use the same. One thing I like to talk to my patients about, again, a chronic gut person as well, like chronic IBS-C with some hypermobility stuff for 20 plus years. So I get it. And something that I think helps, and I think something that is important to talk about in this space often, is that we're not necessarily focused with these diet and lifestyle therapies on a cure, right?
Mhm.
We're focused on symptom relief, yes, like the treatment part of it, but the goal is chronic management, chronic support for our bodies. And I always say that with IBS, and some people, I always joke, you probably want to punch me in the face for saying this, but sometimes I'm thankful that I have the conditions I have, because it's really forced me to really take care of my body at an earlier age. And I don't know what's going to happen. I can't control everything. But the way that I look at it is, what am I trying to put into place that I can sustain long term, that's going
Mhm.
to continue to serve my body well long term? I will grieve what I have to lose with that. I will grieve some of the choices I have to make, but I'm also going to be proactive in figuring out how to make things work well for me. Now, if you're starting with a lot of symptoms right now, not a lot of answers, you're going through the treatment of it all, right? And things are not where you want them to be yet. You're not able to eat a lot of foods. Like, it's hard to look at that and look at what's next and what's ahead. But if you're looking ahead thinking, I just need something that's going to fix me tomorrow, you might be set up for a lot of frustration, especially from a diet perspective, or like gut directed hypnotherapy. Just doing a gut directed hypnotherapy program and then filling your life with a lot of stress and never sleeping and never moving your body and forgetting how to breathe and disconnecting from your life, it's probably not going to be an option, right? Things are going to get worse. You're not going to feel good. And the same is true of diet. You can't go from, okay, I'm going to do a low FODMAP diet, and then I'm going to eat a lot of highly processed foods. I'm going to drink alcohol every night. And then I'm going to, just go into that approach, or I'm going to go to a raw vegan diet and eat all the fiber in the world. Like, it may not work. And so you have to think about, okay, how am I moving forward in a way that's going to be sustainable? And then how do I continue checking in with myself to create that flexibility, to adjust it a little bit, but looking at it as more chronic management. And there's a lot of freedom in that, because it does take away that all or nothingness of it
Yes.
all. And it also
Yep.
takes away some of those expectations of like what's on the other side of
Mhm.
it, and gives you that freedom of, like, if you love pizza and you've tried it again and again, and just the pizza you love isn't working. Okay, how do we modify this? How do we make another version of this? Do we use FODZyme? Do we make our own and figure out how to make an amazing pizza? Do we search out a pizza that is gluten-free if that's what you need? Like, what is it that we need to do to make this work versus I just can't have pizza anymore?
Right.
Just kind of that mind shift.
Right. Okay. Before we wrap up, how can people work with each of you? Do you have to be in California, Stephanie, to work with you, or what's up? We'll start with Stephanie. How can people work with you?
Yeah, so I had 12 state licensures, but they're slowly all going away now that I'm at Cedars. So I apologize. I don't remember the states I'm still licensed in off the top of my head, but definitely California. I can see any patients actually from California at Cedars. If they're out of state, they do have to come in person to be able to see me, but you don't have to be working with the doctor here at Cedars-Sinai to be able to work with me.
Okay, great. And Erin, how about you?
Amazing. I have getovate.com as my website. I do take a limited amount of one-to-one clients. I've pulled back some of that, but I do have an online program. It's a membership and it's geared towards IBS, but there's a forum in there and like live Q&A calls each month. And so we have some stuff on SIBO and some of these specifics, but a lot of those strategies I talked about, there's courses on that, but also some Q&A type of care from me there currently. And then as I have one-to-one client availability, I do see some people, but I also have a great network of dietitians that work in different clinics as well as in private practice. And so if you are searching for a dietitian, always feel free to reach out and I can always do my best to try to put you in the right direction.
And just a few more questions. I have burning mouth syndrome. Sugarless gum is recommended, but it has xylitol in it. I chew 2 pieces a day. Each piece contains 1 milligram. Teeny tiny. Do you think this is hurting my SIBO?
Depends. Sometimes that can cause some gas and some symptoms, but if you are feeling good, and I guess this depends also where you are in your process, but if you are past the treatment process and what you're doing is working and symptoms are pretty well controlled and you're still chewing your gum and you're not having a lot of excess gas, I don't see a problem with it. I'd probably put it close to meals just in case. Xylitol actually can help a lot with teeth health. And so that's one of those like, how do we use this if it may cause more symptoms? But if you are having a lot of gas and bloating throughout the day and you're not sure why, and you're doing, that might be something I would look at of a trial, removing it for a little bit, see what happens, and reintroduce it maybe with 1 piece per day, see how that goes, and then move on from there. But if you're not really having a lot of symptoms, I wouldn't take it away just because.
I completely agree with that. Nothing
Right.
to add.
So what they just described was the thought process for everything. Like experiment, see how you're doing. I mean, it takes a lot of energy. It's like a part-time job. So there are a lot of emotional implications and, like having a lot of grace for yourself, a lot of patience. That's where the resilience comes in, that you have to just like continue on when you want to give up and then just like have that whole pizza anyway. And that may happen. And it doesn't mean that you're going to relapse into a fiery hell. So just hang in there.
Yeah. One thing to add to that, because that reminded me of something, the biggest piece I think that's so helpful for patients is knowing what triggers their symptoms, right? So to Erin's point, if this person is having bloating and didn't know why, then we could find out if it is the gum. And just say if it was, then you can always weigh in the mind, are the mouth symptoms worse than maybe some bloating from the gum? So that's the thing we're always trying to get to. I always tell my patients, if I have them ever cut out something for a certain period of time, that doesn't mean that's how it has to be forever. They always have the choice if they're okay with some of the symptoms they might get from that food when they bring it back in. It's just kind of giving them that power so they can better plan when they have like certain engagements or things like that.
Great. Okay. Erin, your website is gutivate.com.
Correct.
There you go. Okay. Spell it again.
Gutivate.
Okay. Great. Pure monk fruit, is that still okay? Or is it still a problem? Even with 0 alcohol?
I find people tolerate monk fruit pretty well.
Yeah.
I know Stephanie mentioned maybe it's not allowed isn't the right word, but recommended,
Right.
I guess, on the low fermentation. I would say it just depends. Usually what I'm looking at though is if you are, and we didn't talk about like ultra processed foods and like a Mediterranean diet, healthy diet, that's obviously our goal eventually is to get to as well balanced of a diet as we can within each person's needs. But if you're filling your diet with artificial sweeteners, not that I hate them or that there's anything wrong with them, but that fills your entire day. And so you're just grasping at, okay, well, I can't have stevia anymore. I need to like, we may need to look at the flavor palette of what we're eating and like look at things as a whole there too. Not to demonize those things or that you can't have anything from a package and it's just not reasonable, but just something to think about with that.
The bottom line is you have these tools, right? So can you imagine people how many years ago did not have this wisdom and this tools, and they were probably like, what is wrong with me? And I just feel so terrible for people who did not have the science to work with. So Stephanie, do they find you through Cedars-Sinai? How could people in California who want to work with you find you?
They can find me at the Cedars-Sinai. They could type in GI Motility Center and there's a
Okay.
number to call and they can make an appointment there.
Okay, great. All righty. One of the last questions, we just have a few minutes left. I read that sourdough bread is okay, but know that whole wheat bread is a no. A lot of sourdoughs have whole wheat listed in ingredients, for example, organic wheat flour, water, organic stone milled whole wheat flour, sourdough culture salt. Would this type of sourdough be okay for SIBO?
Yeah, I don't know from a low fermentation perspective, but from a FODMAP perspective, the fermentation process does break down the FODMAP in wheat. So most people do tolerate sourdough better. One thing you look for on that label is that culture that shows that it has been slowly fermented. If something has been like more quickly, so the rise of sourdough trends, you do see some that have like yeast added and may not be slowly fermented. So that effect may be less. And then from a SIBO perspective, looking at fermented foods, I know some people don't love high increase of fermented foods. Sourdough is a little bit unique in that you aren't getting live microbes from sourdough. So it's not like kefir or yogurt or kimchi or those foods where you're getting the live microbes. With sourdough, those microbes are cooked out so that they do die, but you're getting the effect from those microbes, meaning that decrease of the fructan or the FODMAP, because microbes feed on sugars. So they're feeding on those FODMAPs. It does still have gluten, so that's something to weed out as well. But if you have non-celiac disease and you're trying to implement some other foods, sourdough is great. Also, a lot of slow fermented sourdough breads that you find are going to be lower fiber in a lot of cases. So sometimes that can be a nice option if like a whole grain fiber rich bread is not a great option for you based on where you're at and the gas production from that. Sourdough can be a fantastic option to kind of test the grain a little bit without so much fiber added. If you want to add fiber, just sprinkle some flaxseed on top, which depending on where you're at may be an option, but that's how I boost the fiber of a sourdough.
Okay, good one. What if you have pots and need electrolytes?
Yeah, I work with a lot of pots. I typically will do a homemade solution. So you can do salt, like a half teaspoon, depending on your recommendation. So we recommend from 3 to 10 grams of salt per day. So it depends on where you're at with that recommendation. But usually the salt solution in water is going to be about half teaspoon of salt in a liter of water. And you do drink it throughout the day. Now, from a meal spacing, again, this is that complexity of overlapping conditions. Usually we will add some sort of flavoring to that, but you can also heavily dilute it more to where you don't have to add any other sweetener to that or lime or lemon to that. You could also, instead of sipping throughout the day, like add 8 ounces with breakfast, 8 ounces with lunch, 8 ounces with dinner, but you still want to spread out the salt throughout the day. And then don't forget that you can add salt to food. So making sure that you're adding it to your meal. So anywhere you can sprinkle, add a little extra salt or sodium, like salt rich foods as well, that you can incorporate, like broths are great for that because they have a lot of salt and sodium in them.
Stephanie?
Yeah, those are great tips. I'm even learning from Erin today. I know she works with a lot of pots. Like she said, I think if they wanted a little bit more control over the ingredients, like liquid IV is one that doesn't have an artificial sweetener.
Oh, good.
And then if you make your own recipe, you can also make it with straight cane sugar. And I think even if they were just having that, but they were still able to space their meals and they're following so many other recommendations, you have to have a significant amount of salt with pots, obviously. And so that might outweigh maybe like not doing the salt because you're afraid of affecting the migrating motor complex. I think when it comes to diet and exactly which specific things trigger it, I do think we still don't have all those details, but I would prefer, I think it's like with the liquid, I think it would be fine.
Last question, LMNT, is that okay?
It has pretty high sodium. So you're looking at 1,000 milligrams or a full gram of sodium. So it is a great rescue option for people with pretty severe like dysautonomia or POTS. It can be really good. In terms of the packets that are flavored, I do believe that they still use stevia. Always have to triple check because I feel like sometimes they change that so much. They do have a non-flavored option. So if you are concerned, I find people tolerate the flavored ones pretty well. I utilize them in my practice sometimes because they do tend to be pretty well tolerated. And again, they are that pretty high amount of sodium. So for like a rescue situation, they're nice. But if you do not want any flavorings added, they do make a non-flavored option. They also have a recipe for their actual formula on their website you can mimic, but they will have the other electrolytes like potassium. I think they have magnesium as well. So they'll round out the electrolytes beyond just salt.
Okay, last question, because we are out of time. Everybody, we have been going since like a long time. How to reduce hydrogen sulfide gas from the colon with diet? That's a biggie.
Yeah, so there were about 3 studies, I believe, with low FODMAP diet and its effect on the gases. And actually, no, I think it was actually hydrogen. I'm not sure if it was hydrogen sulfide now that I'm thinking of it, but the diet tended to have the most impact, like lower fermenting on hydrogen. Can't remember if it's hydrogen sulfide, and then methane had less of an impact with dietary changes. But Erin, I don't know if you know more, if you can correct me.
I also agree. I don't think that there's a hydrogen sulfide diet that
not yet
study that we have yet.
It's just increasing fiber, actually, now that I'm thinking of another study, increasing fiber had the most impact on sulfide versus reducing sulfur in the diet or protein in the diet.
Oh, interesting. Okay. let's put some love into the Q&A box and some hearts for these two genius, incredible RDNs. Thank you very much, Stephanie. Thank you, Erin. That was great. Really, really helpful.
Thanks so
So
much.
there is a lot of hope, everybody. And get with one of these fabulous people to support you. And their cookbooks also, if you're bored, because I see some people say, I'm sick of this food. Like there's some great cookbooks out there and great recipes online too. So thank you very much, ladies.
Bye.
Thank you. Thanks,
Bye-bye.
everyone.
Thank you. Take care. What a great SIBO Awareness Day 2026. Thank you so much for your participation and your attention. And thanks to the organizers for inviting me to be the host today. I am truly honored. And I hope that today you're not overwhelmed. Instead, you're inspired and will take right action. And doing things in the right order, I think, is really important. Be sure to check out SIBOawareness.org and make sure you're subscribed to their emails. They're taking all the unanswered questions and will answer as many as possible in their email newsletter. That's fantastic. They're also constantly adding new research, ongoing resources, and FAQs. So it's a great newsletter to be on so you can stay up to date with the latest and greatest research. I'm Siobhan Sarna. Thank you so much for being with us today. What an honor and pleasure, and spread the word. Get SIBO awareness out there, educate your friends, your family, your practitioners, because in some cases, I know some of you are going to know more than they do, but that's just because they didn't learn about it in school. Their intention, I'm sure, was to heal people, and hopefully they'll be very open to what you are suggesting and sharing with them. And that is the way we change the world, by one tummy at a time, as they say. So thank you very much to the team. Oh, mwah. Bye, everybody. Thank you. Thanks, everyone. Thanks, guys.